Hi, folks. Thank you so much for joining us today. I know we have just a ton of interest in this session today, and I could not be more thrilled for this. So I know folks are still joining. So while we're giving them an opportunity to log in, I wanted to introduce this session today and our incredible speakers. So I'm Kim Workmeister. I'm the Senior Vice President for Improvement and Implementation for Convergence Health. I'm joined by my colleague, Helen Craigie. The two of us have, if you've participated in any of our educational events in the last year or so, you know you've gotten to know us pretty well too. And today, rather than having you hear from us, we are just thrilled to bring our two incredible speakers from Providence Mission Hospital in Southern California. A little bit about Providence Mission Hospital. I have a very personal connection to that organization, as I also have the incredible honor of getting to be the chair of their patient family advisory council there too. That comes as a result of some great care and treatment that family members of mine received there. So I've been a big fan of theirs for a long time, and they continue to do really, really incredible work when it comes to improving outcomes for patients, improving the conditions in which care is provided by healthcare workers, and really just bringing the patient and family to the center of the conversation that we have. So briefly, I wanted to introduce our speakers here. So um, uh, Mujan Rezvan is the supervisor of interpreter services at Providence Mission Hospital. She holds a bachelor's degree in healthcare administration and a master's in business administration. She oversees the interpreter services department, which includes 60 dual role interpreters. Her team is dedicated to providing high quality and linguistically appropriate care that bridges the communication gap between the care team and patients. As a qualified medical interpreter, Bhujan brings a unique perspective and personal commitment to her role. Having learned English as an adult, she understands the challenges faced by patients with limited English proficiency. This personal experience fuels her passion for removing language barriers and advocating for patient rights, ensuring that all patients receive the best possible care and outcomes. In 2023, Providence invited employees to apply for a health equity fellowship, proposing a quality improvement project focused on health equity. Mujan was one of the 20 fellows selected for this fellowship cohort across the entire Providence system. This achievement further demonstrates her commitment to advancing health equity and improving healthcare delivery through innovative solutions. Emily Cusick received a bachelor's degree in communication from the University of Southern California. She then went to work for a market research firm in Los Angeles that supported clients including Disney, Miller Coors, and Johnson & Johnson. It was through her work on a study for Johnson & Johnson that she became familiar with the medical field. After obtaining a bachelor's of science in nursing from Concordia University, Irvine, she began her nursing career in 2013 in the neuro ICU at the University of Colorado Hospital. With her background in neurosurgical intensive care, she came to Providence Mission Hospital in 2016 to work in their neurosurgical and trauma ICU, where she developed a passion for the sepsis care pathway and sepsis patients. She joined the sepsis response nurse team in 2021 and became the sepsis clinical coordinator in 2022. In this role, she incorporates previous work experience and success in market research to strengthen and support the hospital's sepsis program. So with that, I am going to turn it over to Mujan and Emily, and would ask that as they're speaking, if you have questions that come up, use that chat box on the right-hand side of your screen. Type in questions. Helen and I are going to be monitoring that throughout. And at the end of the presentation, we'll go through as many questions as we can get to. And of course, we will be sharing the slides and recordings from this probably likely by Friday once everything is available. So Mujan and Emily, I'll hand it over to you.
Thank you so much, Kim. Good morning, everybody. Good afternoon, depending on where you are. Thank you for having us today. We're very excited to be here and share our project with you. So today with me, I'm Mujan Rezvan. I have Emily Cusick, my project co-lead, and Kapitsi Para-Thornton, one of my project sponsors, here with us. And as Kim was mentioning, this whole project really happened because of a Providence Health Equity Fellowship. I'm not going to go over the whole slide, but in 2020, Providence made a 6-year commitment to spend $50 million on advancing health equity. And that's how this fellowship started. And that's how I got involved. And we got to do this awesome project. So before we get into anything, I just want to go over a little bit of glossary, dictionary, vocabulary check. I don't know if everyone here is familiar with sepsis. So sepsis is the body's toxic response to an infection, and it occurs when your body starts to attack itself rather than the infection. Sepsis is the leading cause of death in hospitals. Each year, at least 1.7 million adults in US develop sepsis, and nearly 270,000 die as a result. An LEP person is a very important vocabulary to know in this presentation. A person with limited English proficiency, LEP, is someone who does not speak English as their primary language and has a limited ability to read, speak, write, or understand English. Length of stay is the duration of a single episode of hospitalization, and 30-day readmission is unplanned readmissions to the hospital within 30 days after being discharged. And readmission observed to expected ratio, O to E, is an observed readmission is the actual number of readmission. Expected is the predicted number based on the patient's readmission risk. So these are the vocabularies that we're going to use throughout this presentation. So why are we even here? We have a project I want to talk to you about. This project really started because our initial data analysis showed that sepsis patients with limited English proficiency, or LEP patients, are staying at our hospital longer, and they're being readmitted at a higher rate compared to English-speaking patients. And we really wanted to know why. So the goal of this project was to identify and address the factors that are contributing to this disparity in the data. And here I have our baseline data. On the left side of the screen, you see the comparison between English population and LEP population for readmission observed to expected. And on the right side of the screen, you see the comparison between average length of stay for English-speaking patients and LEP patients. And as you can see, they both are higher. The green bar is bigger than the blue bar. So since this is a process improvement, quality improvement project, we really had to set a smart aim for this project. So we started back in September. This was supposed to be a 10-month project. So we said by end of June, we're going to reduce the average length of stay by 1 day. So going from 8.66 days to 7.66 days. And we're going to decrease the 30-day readmission rate from 1.23 to 1. And the project outcomes or outcome measures for this project are obviously the average length of stay for LEP patients, sepsis LEP patients, and the 30-day readmission rate observed to expected for LEP sepsis patients. So at the beginning, we had some ideas. We were thinking, okay, why is this happening? And we had some ideas. We're thinking, is it because an interpreter is not being used? It is because we're not telling them what to do at discharge planning. Maybe it's case management that's not involved, or they're delayed, or what are the barriers? We really wanted to know, but we didn't want to hypothesize. We just wanted to dig into it, and we didn't want to jump into a conclusion. And that's when we decided to hear it from the patients. And that's when we decided to do a patient focus group. So we conducted a Spanish-speaking patients and family members focus group. We contacted 90 patients. We looked at our previous data, our baseline data, basically. We contacted 90 patients who were being treated for sepsis as one of their diagnoses, and had a longer than expected length of stay, depending on their diagnosis, and had a readmission within 30 days of discharge. And these are all Spanish-speaking patients. Out of the 90 patients we contacted, 16 patients agreed to join us for the focus group. And on the day of the event, 8 people showed up. And the room set up, we had the whole focus group going on in room 1, which all the conversation was in Spanish. There were the participants and the moderators, Spanish conversation only. And in room 2, it was me, Emily, and some of the other team members with the Spanish interpreter providing simultaneous interpretation for us to understand.
Thanks, Mujan. So the importance we thought of having the 2 rooms was not to detract from the conversations that were happening in the room. We wanted to get as real a feedback as possible, and then also be able to message the moderators real time if we wanted to ask a different question or dig deeper into something that one of the participants had said. After the focus group, we took the findings and categorized them into 4 different topics. We heard findings that related to difficulty in understanding the disease process. So not understanding sepsis, not understanding how it was treated, what to do after discharge, some of them, the majority of them not actually understanding that they had sepsis. The second category, listening to build trust. Trust was a really big category for us. We found that once trust was broken, it was really challenging to earn it back, and it seemed to affect some of the participants' health afterwards, in terms of maybe they weren't taking medications prescribed because they didn't trust the medical team. The third was enhancing communication with the care team. We found there were difficulties, as you can imagine, with different languages being spoken, not everything maybe was being communicated with the care team in terms of symptoms or treatment plan, things like that. And then we found difficulty in post-discharge care as well. So I'm going to go over some quotes from the focus group, and some of these are very raw. Many of them we are not proud of, that this is the experience that some of our patients had had, but they were really important for us to understand how we can help and where opportunities were, and just better understand the challenges of our LEP patients. Here, let me get the right click here. So the first category, understanding the disease process. There was a patient who said, I went to the hospital, my blood pressure was dropping quite a bit, but they never told me what I had, only theories. No one knew the reason. I came in and things were explained poorly. They did a lot of studies, but they didn't find anything and sent me back home. They didn't tell me what was wrong, but they told my husband. And I was very sick to my stomach. I couldn't stand up. They explained what they would do, but I didn't understand. And I think these all relate to different patients' experiences, where I'm sure the clinical team had an idea. They had diagnoses. When we reviewed the charts, they had discharge summaries that all discussed sepsis and the patient's care, but the patients didn't understand. And there was a break there in communication, where the providers, in even these specific cases of the respondents in our focus group, had an idea and the medical team had an idea of the patient's disease process, but the patients weren't absorbing that. They weren't understanding. Listening to build trust. As I mentioned, this is a really important category. This first quote is from a patient who was receiving IV potassium. And I'm not sure if all of you are aware, but IV potassium typically can be kind of irritating to the vessels of the patient, which is it's a relatively normal experience to have that side effect for the nurse. But for the patient who wasn't understanding, I think this was actually quite scary. So she was receiving the potassium. She didn't know what it was, and it was painful. And she said she tried with what little English I had and said, it hurts. My son was there and says, don't you see? She says, it hurts. Don't put it there. And she didn't listen. And I can imagine as a patient receiving an IV, and all the other IV medications were not painful, but then to get one that was and feel like you're not being heard, I can imagine that she was very afraid and thinking it could be who knows what's going on, when in reality it was maybe something that wouldn't actually cause harm. Another respondent said nurses don't listen to you, they don't give medications on time. And I felt very poorly, like I was choking. I took the pill and I was choking. I was desperate, turning and spinning, and I still have back pain from that. The doctor had me do a swallow type study and then x-rays. They didn't say a thing, not even the nurses. She made me take pills. And I just want to go back to the not giving medications on time. Um, Many times medication timing is adjusted by pharmacy or providers in the hospital, and sometimes they're given at different times based on different medication interactions. But if we can't communicate that to the patient and they just know that at home I take my medication at 8 a.m., why are you giving it to me at 10? There's that feeling of distrust and thinking that you're not getting medications correctly, even though there is a reason. But if it's not communicated, then they wouldn't understand. When one doesn't understand the language, how can you explain? They don't pay attention to you. So the third category, enhancing communication with the care team. Ensuring important symptoms are communicated with the team, and the provider is only going to order a test if they're aware of the symptom. And if it is a symptom, like in this first case, I believe it was stomach pain. So the patient was having stomach pain for about 4 to 5 days. They'd had a CT abdomen pelvis on admission, but then it was not communicated effectively about the stomach pain until about 4 to 5 days later, when they did do a follow-up and the patient needed surgery. And our question was, what if we had caught that sooner? What if it was understood sooner? Maybe we could help patients with particularly length of stay. I didn't want more insulin because I wasn't eating. I kept throwing up, but they didn't listen to me. They didn't want to hear it. This is another patient who had ordered insulin for even if they weren't eating. So even if they were NPO or were not eating, they were still getting daily insulin, but it was like a half dose. But again, if this isn't communicated well, then the patient thinks, usually at home, I don't take insulin if I'm not eating, and then trust is lost, but then also maybe there is a longer length of stay because of treatment plans not being followed. And I had trouble sometimes asking for an interpreter. And the final category that we identified was how to care for themselves post-discharge. And this really goes into our readmission goal of reducing readmission. So they told her it was a minor issue. This is a family member of a patient that came. She had a high temp. Weeks went by. She didn't get better. She was worse. Her main doctor never saw her again. They did a lot of studies, but they didn't find anything. And they sent me back home. Whatever I ate, I threw up and I got very sick and I went back to the hospital. And they told me to check my blood pressure. I left all the medications they gave me. I didn't want anything to do with that. And this quote in particular was really important, I think, because the patient had been prescribed antibiotics post-discharge. And with sepsis, antibiotics are very important. It's important to take them the whole way through. And if they aren't taken, your risk for readmission is higher and getting sick again and with a more resistant pathogen. So the break in trust with that patient then carried on to post-discharge and taking the medications that were prescribed as prescribed.
So after we listened to everybody, we found out that it's all connected. What's happening at the hospital and what's happening after they leave the hospital, which is the right before coming back to the hospital if they have to be readmitted. It is all connected. So listening to these patients sharing this information with us, as Emily mentioned, there were very powerful, strong comments that they were sharing. So we decided to take those comments and design our project interventions around those categories that we found out. The before the hospital, at the hospital, and after discharge. So for before the hospital, we decided to partner up with a community clinic in our community and also our own community health investment team to provide education, increase access to care, and also address the barriers in the community that we're not able to address in the hospital. For at the hospital category, we decided to provide more educational material in the patient's preferred language, so the patient can actually truly understand what's going on, and use the teach back method, asking them, okay, now you teach back to me, you tell me what you learned, and really enhancing the communication with the care team. And for after the discharge or after the hospital, really post-discharge follow-up. Calling them, making sure they're okay. Did you finish your antibiotics? Did you schedule the appointment? Do you need help? Do you have any question? And also referrals to community services as needed, because some patients had needed extra help that we weren't able to provide to them at the hospital. And that is when we decided to introduce the role of a sepsis nurse navigator. So for the sake of this project, we created this internal role. Emily and I got together, we basically created a job description and a workflow, and we asked our own nurses if they wanted to be a part of this project. And we found this 4 awesome nurses to participate in our project. So we have Maristel, Berto, Marita, and Fabi. 3 of these nurses are bilingual Spanish, qualified bilingual Spanish speakers. 2 of them are actually Spanish interpreters. And for any other languages, they use interpreter services and are interpreters available at the hospital. So we created a schedule for 4 to 5 days a week. They're here from 8 to 2:30 or 3 p.m. And they have a workflow that they follow. When we created this role, we had to communicate this with the rest of the hospital. So we created this flyer introducing the sepsis nurse navigator pilot role to the rest of the hospital, telling everyone, hey, we have this resource available, working with LEP patients. We want to ensure that you are actually using them as well. If you have a patient that you think can benefit from the service, please call us. We put the phone number on the flyer and really try to advocate for this role. And another thing that we did was that we changed the color of their scrub. Our nurses at our hospital wear blue color scrubs. And at the beginning of the project, we noticed that, oh, we really need to differentiate them from the floor nurses, because especially these are our own nurses. Everybody knows them, especially when they were going back to their home units. It was a little challenging for them because they would get called for other things while they were there as the navigator. So we really decided to differentiate them with this color scrub, and also we ordered them a navigator lab coat with their credentials on the lab coat, and also with the name of sepsis nurse navigator. I think you're muted, Emily.
You. Sorry about that. So the workflow was important because we wanted to focus them in on the ways that we could have them be effective for our goals. So I don't think I won't go through all of this, but I know the slides are coming through. But the first part, which sometimes was the trickiest, was identifying patients and adding them to our we had a separate Epic list that was shared amongst the navigators, and an Excel tracker also shared. It's difficult to always identify sepsis patients in-house because we don't truly know. There's a lot of tests being done. We're waiting for cultures to come back, other labs.
I got your message and I was just calling you back to walk you through how to drop off.
Let me see if I could. Oh, someone already figured it out. Okay. However, so what we used to identify the patients was a sepsis order set. And we have For our present on arrival patients, we have about 85% of our sepsis patients receive the order set. So we were grabbing a good number of them. And the other patients that were coming through is one of the reasons why we had the flyer for the not present on arrival. So we could share it with the units, have the nurses round on the navigators round on the unit and say, do you have anyone new with sepsis who is limited English proficiency, and trying to find ways to add them to our list if they maybe had missed that order set. But then, of course, some patients who have the sepsis order set don't end up having sepsis. As the coordinator, I'm glad that they get the workup. Better safe than sorry from my perspective. But then they would have to, the navigators would need to do a review of the medical record to make sure that the provider team was still considering sepsis and it wasn't just something that had been ruled out. A big part of the navigator's role was to team up with a lot of different groups. So it includes the case management, the bedside nurse, really working on empowering and educating them. Are you comfortable with using the interpreter? Do you have the app? Any support that they could give them, rounding on new patients, confirming things like insurance. Insurance needs were a big finding that we had, where if we could jump on that early in the patient's stay, it would really help support them out of the hospital. Not necessarily the in-hospital coverage, but after discharge, having support for those follow-up appointments and any follow-up procedures that might have been needed. Best contact numbers, so we could do a follow-up call, preferred pharmacies, see if we could support with medication access at all as soon as possible. Determine any barriers, referrals to community health clinics or navigators, and assessing their knowledge of the disease process. Providing educational handouts, one-on-one, as Mujan mentioned with Teach Back, was very important. And I think the rounding would also build trust, and getting a follow-up call from the navigator as well to build trust that someone was watching out for them. And following up with the primary nurse and documenting the encounter. Let's see. So this is a tool that we gave the navigators. It's mainly focused on a patient with a diagnosis-related group, a diagnosis of 871, which is someone with sepsis without ventilation, so not being intubated for 96 hours or more. So either not being intubated at all or for a short period of time, with major comorbid conditions, which are listed at the bottom. So it was just sort of a day-by-day check to see, was the patient progressing? Are they improving? Are their oxygen needs improving? Have they had the education? Have we collaborated with case management, discharge planning, things like that? Looking at the microbiology cultures, ensuring that they're receiving appropriate antibiotics. It was a big role of collaboration, but then also following the clinical progression. These are pulled from our Excel document where we were tracking the patient, and we had our most important were the sort of the information about the patient so that they could be followed and tracked: language, discharge date and location, phone number for discharge calls. And then here we were looking at discharge readiness. So things like organ dysfunction, is it resolving? Are they on pressors? Following their lactate, which is indicating perfusion for us. Are they on supplemental oxygen? How is their cardiovascular system, electrolytes, nutrition, transitioning to oral antibiotics, probiotic to reduce risk for later infection, early mobility, another evidence-based indicator for improvement, and pain. And then post-discharge, we kept track of the calls, the education provided, and then these categories were really important that we wanted to try and identify where the biggest needs were. So was it with making a follow-up appointment, medication access? Many of our patients were also diabetic, and that was a big aspect of accessing glucometers, accessing strips, challenges with making sure that the order matched the brand that their insurance would cover. or was generic enough that the pharmacy could give them the one that their insurance covered, medication education, and referral to community services. And then general notes. So we had, I think, I'll show you the folders are next. So with the post-discharge calls, as I mentioned, I think I went over all of this, but these were the topics that the navigators would make sure that the patients were supported in, give their number for calls if they had any questions or problems. And these are some of the questions. So we gave the navigators a script for the follow-up calls. Our navigators are wonderful nurses. We're very passionate and compassionate. And without the script, the calls would be 3 hours long, maybe. So we tried to narrow it down to make sure that we not only asked all the questions and made sure we had all the different topics supported, but also to kind of help focus the calls if they were going into just more relational discussions. So have you picked up your so these are all medication compliance. Have you picked it up? Are you taking this prescribed? Just trying to make sure that these topics that would really help support the patient and their discharge. This color zone education is one of the documents that the navigators would provide the patients before discharge, where it had a different color zone with symptoms so they could understand something about sepsis after discharge. You don't feel 100%. You don't feel like you did before you were sick. There is a period of recovery and rehabilitation, and we wanted to help the patients understand that so they didn't go home and think, why did they discharge me? I'm not better. I still need my family to help me. I still need support. I'm still feeling sick. So we gave them this color zone education translated in their language to help them understand what would be expected and what would not. And then here at the end, we asked them to call if they had any questions. And then if you come back to the ED, we wanted to give them that continuing support and be able to meet them where they were at. And if they were on shift, be able to arrive at the ED to support them if they came back. And these were just a way that we used to organize the post-discharge scripts. So we had the blank copies. The green was for calls made, and then the red was for calls were made but needed follow-up. So they, for whatever reason, needed more support in obtaining an appointment, insurance perhaps, just so follow-up to make sure they were taking their medications or blood sugar was in range, things of that sort.
So one of the things that we really focused on was education. We created this comprehensive educational material. Our sepsis team created this. It's 10 pages, and we also translated this document into our top 4 languages in the hospital, which are Spanish, Farsi, Arabic, and simplified Chinese, because we wanted to make sure patients are receiving the education in their preferred language, and we wanted to make sure we're providing linguistically appropriate care. Also, this is the documentation that Emily was speaking about, the green, yellow, red zone. This is another educational material that the navigators provide to the patient while they're round on them. They will tell them about what is okay, what is it that you have to keep an eye on, and under what circumstance you should come back to the hospital. We also translated this document into our top 4 languages, which are Spanish, Farsi, Arabic, and simplified Chinese. And if you're wondering why the green is on the right side on these languages, is because Arabic and Farsi read from right to left, and it's completely opposite. On the next slide, I have a video for you guys. It's part of the educational material that we created. I have the English version of the video, but we also created the video in the other top 4 languages. So let's watch it together.
During your hospital stay, you may have heard your caregivers talk about sepsis. Sepsis is a serious condition caused when the body overreacts as it fights infection. Not all infections lead to sepsis. However, If an infection goes untreated, bacteria can enter the bloodstream and cause an overwhelming toxic response. Without treatment, sepsis can cause organ failure and death. Common sources of infection include pneumonia, urinary tract infections, wounds, and abdominal infections. Sepsis patients may receive IV fluids, antibiotics, and tests to find and treat the infection. For serious cases, life support may be offered. You will be monitored closely by your team. We will talk with you and your loved ones about life support, such as a breathing machine if needed. Our goal is for patients and their loved ones to be involved in care choices. We will help you know what to expect during and after the hospital stay. We welcome patients and their loved ones to identify a family spokesperson or power of attorney for healthcare, review advance directive information and goals of treatment, request meetings with your care team, including physician, care management, palliative care, and others. After leaving the hospital, you will continue your recovery at another facility or at home. Discharge planners and care managers will work with patients and families to coordinate a smooth transition out of the hospital. You may not feel back to yourself at discharge. You will continue your recovery at home and will need support. To ensure a smooth and full recovery, it's important to do the following. Finish all your antibiotics, even if you are feeling better. To rebuild strength, stay active even when you're not feeling well. It is important to get out of bed. It can take weeks or even months to recover. We call this post-sepsis syndrome. See your primary care provider within 1 to 2 weeks of leaving the hospital. We hope this helps you understand more about sepsis. During your
Okay, so we also, as I mentioned, we also have this video available in 4 other languages, Spanish, Farsi, and Arabic. Here are some QR codes if you guys want to go ahead and scan them. They're uploaded on YouTube. And when the navigators go rounding on the patients, they have their iPads with them. And all these videos are uploaded on the iPad as well, where they'll charting, whatever they had a conversation with the patient, they put the video on the iPad, they hand it to the patient, and they have them watch it. They also have the QR codes printed for them if they want to share it with their family member or their loved ones. So again, this was a process improvement, quality improvement project. So we had to have some process measures and key drivers. And here is a list of our process measures. I'm not going to read them all, but we needed to make sure what we're doing is actually working, and it's really helping the patient, most importantly, and it's really helping us getting close to the goal that we have. So here I have some information with you so far from our program. So we started in mid-September, and this data is updated until end of May. So 9 months worth of data. During our project, 214 patients were followed by our program. 92% of these patients were rounded on, a total of 432 rounds on 196 patients. 87% of our patients received a follow-up call from us. Some of these patients received more than one because we performed a total of 438 follow-up calls and 187 patients. 93% of our patients received created educational material about sepsis. 85% of our patients received Mission Hospital created sepsis educational material. And on the right side of the screen, these are mainly focused on the post-discharge care. 10 patients needed help scheduling a follow-up appointment. 23 patients needed education on their prescribed medication after discharge. 18 patients needed help accessing their medication. It could be copay or it could be a pharmacy issue. And we also referred 23 patients to our community clinic and 28 referrals to our community nurse navigator who is active out in the community and helps with the issues that the patient have that we can't help at the hospital. Here I have some data to share with you, which I think is the most exciting part of this project. So on the left side of the screen, we're looking at the average length of stay data. The blue line is for English-speaking patients, and the green line is for LEP patients. And what you see on the left side of the chart is the baseline data, and what you see on the right side of the chart is the current data. And this is from the beginning of the project, which was mid-September to end of May. And as you can see, we had a reduction of 24% in our average length of stay for our LEP patients. And that is a statistically significant data because our p-value is smaller than 0.5. And that is pretty impressive. We're so proud of this number. On the right side of the screen, we're looking at the readmission, the 30-day readmission observed to expected comparison. Again, the blue line is English-speaking patients, and the green line is LEP patients. And on the left side of the chart, we see the baseline data, and on the right side of the chart, we see the current data. And we had a reduction of 33% in our readmission rate. The English-speaking population actually didn't really change. They went the other direction, which is sad, but we didn't take anything away from that population. We just didn't implement our interventions that we were implementing with our LEP patients with English-speaking patients as well. And this is data that we're proud of it, and we keep getting new data as we go through the project every month. So after we did the project for a while, we wanted to really know, we were looking at the data, we knew it was working, but we really wanted to hear it from the patients. So we decided to do another focus group. But this time we decided to invite the patients that received some sort of interventions throughout our projects. So we contacted 101 patients who were treated for sepsis during the time of our project and received at least one intervention throughout our project. Out of the 101 patients, and these are all Spanish-speaking patients as well, because Spanish is our highest speaking language in our hospital. Out of the 101 patients we contacted, 29 agreed to join for the patient focus group. And out of the 29, 19 showed up on the day of. And our room setup, again, was very similar to how we had it last time. In room 1, it was the focus group, the participants and the moderators in Spanish conversations only. And room 2, it was Emily, me, and the rest of the team with a Spanish-speaking interpreter providing simultaneous interpretation.
So just to quickly go over the 4 categories that we had identified from the first focus group, these were not shared with participants in the focus group, but we reviewed them again when we were going over our notes from this group as well. So the 4 opportunities we had identified: understanding the disease process, listening to build trust, enhancing communication with the care team, and post-discharge care. So understanding the disease process, and I just want to point out, I'll go over these quotes a little bit more quickly, but the shift in the tone and the experience of the patients who'd received the supportive interventions we'd put in place. I was very well informed. They used an interpreter in person. Before this, I hadn't heard about sepsis. In her previous hospitalization, Hispanics don't talk much about sepsis. We don't think it's very common. And they came over to help with my diabetes. They taught me how to do a few things, and they gave me the little guides. And the little guides that they were referring to were the education packets that we had translated. So we saw in this focus group, the understanding of sepsis had shifted quite a bit in comparison to the first group. Many people knew about it. Many people even on their own commented on the fact that they hadn't heard about it from before. Listening to build trust. A nurse came to see me who was an expert in sepsis. The guides, when they said the guides, they were referring to the navigators. They didn't always know their official titles. Explained to us, and the pamphlets that they gave us. The truth is, when you came to talk to us, we found out things the doctor had not told us about. With the nurse navigators, we could learn a little bit more and get more information that we needed. Another patient, I was in a coma for a month. I appreciated all my life and the attention you gave me and everything you provided. I have a lot of respect for the care. And this quote could also go along with understanding the disease process. There was a lot of overlap in the different comments and the findings. Enhancing communication with the team, with the navigators, we were well informed. They always kept me in touch with the process. They always were available, like Berta, many of them named our navigators by name, and I believe that's because of the continued, the continuity of care that they received, where a few navigators were checking in on them over their stay. And how to care for themselves post-discharge. They called me and asked if I needed help, and to call, thank you, thank you, thank you for all the help you gave me. They called me after I was released. They called me at home. I finished my antibiotics and I saw my doctor because I needed more. And that was such a big win from a sepsis perspective, because the first group was saying that they weren't even taking their antibiotics post-discharge. And this patient not only took them, but finished them and reached out to their doctor because they were still not feeling well. And then also this patient was aware if I felt unwell or uncomfortable, I should call the navigators. Let's see. So we pulled from these our 3 main interventions that we found seem to have the most impact. And the first was the education materials. Many of these education materials we already had. Some of them were created just for the project, but they weren't translated in these patients' languages. And we saw how important that was. In-person rounding, building trust, enhancing communication with the care team, the circling back with the bedside nurse, sometimes reaching out to providers as the navigator with perhaps a new symptom or a concern, and then those follow-up calls, helping to make sure that there's medication compliance, follow-up appointments were being made, accessing care from appropriate sources, like if they needed a referral.
So something very fascinating that I think it's important to note is the fact that the patients who participated in the second focus group didn't know anything about the first focus group challenges and the categories we identified. We did this project, we started it in mid-September, and 8 months later in April, we had the second focus group. We didn't share anything with them, but yet they brought up comments which fit right into those categories, but in a positive way. And what we shared in both focus groups what was shared in both focus groups were similarly in the same categories, but one was very positive and one was negative. And what the second focus group had positively experienced was what the first focus group had asked for. And I think that's a big win for us. To wrap us up, we have a video here. We call it a Grateful Patient Story video that we wanted to share with you guys. And before I play the video, I just want to say one thing, that quality care is equitable care. And there is no quality without equity. So let's watch this video together.
Cuando estaba en casa, empecé con el dolor de una muela y luego se me quitó el dolor de la muela. Como a los 2 días se me empezó a infectar.
احساس ضعف داشتم، توان راه رفتن نداشتم، احساس کردم گیجم، یه جوری حال خوبی نداشتم.
Pues yo estuve enfermo de una infección en mi pie izquierdo y llegué aquí al hospital.
زود تلفن زدم به برای گروه امدادی 911 اونا اومدن و ما مستقیم رفتیم ترانسپورتش کردن به میشن هاسپیتال.
Y ya me trajeron de emergencia, nada más recuerdo que me dijeron que me iban a hacer una pequeña cirugía para que la infección no se fuera para mi cerebro y mis pulmones y al corazón.
Y ese tipo de infección no nomás estaba dañando mi herida, también mi organismo.
سپسیس نرس نویگیتر خودشو معرفی کرد و شروع کرد راجع به سپسیس به من توضیح دادن. من اصلا نمیدونستم سپسیس چیه. هیچ وقت این کلمه رو اصلا نشنیده بودم.
Ya no me acuerdo nada. 24 días sin abrir los ojos y sin poder hablar. Lo abría por medio minuto, pero no podía hablar. De un papel que me dieron, anoté el nombre de mi mamá y el nombre de mi hermano. Porque pensaba mucho en mi mamá. Y ya los enfermeros me dijeron que todo iba a estar bien porque mi mente ya iba regresando otra vez. Ya iba regresando.
Pues gracias a Dios me atendieron muy bien y gracias a Dios ya mi herida, mi infección ya sanó. Ya no tengo problemas de eso.
Por un dolor de una muela, de que yo iba a estar tanto tiempo en un hospital o de que me iban a hacer todo eso solo por una muela.
Yo igual no entendía, más bien yo no hablo inglés y pues el doctor me pusieron un traductor para que la persona que me traduciera me explicara mejor en español. Y es donde yo entendí todo ese tipo de problemas y consecuencias que podría tener la infección.
خودم عادت ندارم خیلی کمک بگیرم از دیگران. وقتی هم اون روز اومدن برای آموزش سپسیس من گفتم که مترجم نمیخوام، میفهمم. خب خیلی هاشم میفهمیدم، ولی وقتی کلمات تخصصی میشه برای من درکش مشکل میشه. سعی میکنم بقیه داستانو بفهمم، ولی مطمئناً اون روز اگر مترجم نبود من کامل نمیفهمیدم که موضوع چیه و این مترجم خیلی به من کمک کرد.
Sí, nos sentíamos apoyados porque podíamos entender lo que ellos nos decían, ¿no? O ellos nos entendían a nosotros.
Cuando me hablaban en inglés me sentía solo porque no podía hablar o conversar.
Era muy importante saber qué era lo que me estaba pasando para seguir con mis tratamientos.
بعد چند روز کم کم حالم بهتر شد و رفتم خونه. وقتی رفتیم خونه اونا با همسرم در تماس بودن، فابی و برتو.
فالوآپ کرده بود که مطمئن بشه که ما مشکلی نخواهیم داشت.
اتفاقا من سوال داشتم راجع به دوز داروهام و میخواستم بدونم که حالا چه مقداری باید مصرف کنم که برتو جواب داد. خب این توی تایم برای صرفه جویی بود دیگه، لازم نبود دوباره حتما از دکترم بپرسم.
Señor Beto, de Fabi, de Luz María, porque gracias a ellos también pues me sentí a gusto y contento porque todo el tiempo que estuvieron conmigo tratándome, enseñándome.
وقتی که مراجعه میکنم به بیمارستان، وقتی احساس کنم که اونا حواسشون به من هست و دقت میکنن، به سلامتی من اهمیت میدن، خب خودم احساس راحتی میکنم. دیگه نگران نیستم. فکر نمیکنم من تو این کشور یه آدم غریبه‌ام. نمیتونم راحت با اینا ارتباط برقرار کنم.
Pues dándole muchísimas gracias por su apoyo, todo lo que hicieron por nosotros y siguen haciendo por nosotros, por mi vida.
Y gracias a Dios estoy muy bien y aprendí muchas cosas de ellos que nunca se me va a olvidar y siempre voy a estar eternamente agradecido.
Well, Mujan and Emily, what an incredible way to end this presentation. I cannot tell, I don't think I can count actually the number of private messages I've been receiving throughout this with folks that we work with across the country saying, "Oh my goodness, can we share this? Oh my goodness, this is what an incredible way to look at equity." I'm honored that you had time to share with us today. I think, you know, I'm seeing if we have questions here, a couple of questions. One about making sure we will be sharing the materials, and the videos should be able to be played within that. I'll make sure that's available to folks. And really, just as we think through then different ways that we are looking at equity here, first starting with, of course, the patients that we're serving, talking with them. And I think as Emily and Mujan pointed out, you're not always going to hear something that you want to hear. But that's the way that we learn and move forward. That's the way that we can actually improve and truly be patient-centered in the mission that we all have in caring for our patients too. Your outcomes are incredible. And you know, for folks who are thinking, well, we don't have all of these resources. We don't, you know, we're in a very, very small organization. How could we, you know, do the same thing here? And that's okay. How can you start small? I mean, just even in the way that you are looking at your data. I mean, I think a lot of us look at data and say, you know, well, we stratified it by race and ethnicity. How about language? Have you thought about looking at low English proficiency patients in your organization? And is there a difference there? Just another idea to think through what we look at. You might even be looking at different zip codes where your patients are coming through. Is there a difference in the different zip codes that are coming through? Or folks that answer the 5 social drivers from health screening questions that we're all doing now too. Is there a difference in folks who answer in the affirmative to some of those questions? So just food for thought, different ways that we can be thinking about really improving equity and at the same time improving outcomes for patients. And I would say that it's seeing these stories from the patients too, as a nurse myself, hearing the effect that this has had on the patients that you serve also helps our team members too, doesn't it? To see that we really are part of something big and we really are making a difference in the world and in our community that we serve. So if any other questions here, if anyone wanted to unmute your line and ask a question live or anything else in the chat box here, I think I have hit all of them. Just give it a moment if anyone wanted to unmute and ask a question.
I just want to say quickly that Mujan and I really appreciate the time to share the project. Our patients and our community are very important to us, and spreading the message and for this population of people that maybe isn't always looked at as closely is really important. Anything we can do to support them and ease their way is success for our aim.
Well, that certainly shines through in this here. So we're getting a lot of requests too, folks. I hope you'll be willing to share this in other places too. So we just opened a big Pandora's box. So I hope that we will be hearing your stories for a long time and really appreciate you sharing too. So for everyone here, as I said, we will send all of the information out to everyone online, and we'll share the speaker's contact information too. I see that request. Everything should be going out along with the recording by Friday. So we will have that. All right, folks, thank you so much and have a wonderful day. This concludes our webinar for today. Thanks.
Thank you all for having us.